Previously, we discussed ABGs and how important they are. Respiratory failure happens when a patient's unable to maintain adequate blood gas values. I'm just reading this to you. The abnormality of gas exchange with either an excess of carbon dioxide, which is capnia, or a deficit of oxygen, hypoxemia, or both. ABG values define respiratory failure with PaO2, so that's the pressure of the oxygen, is less than 50 to 60, and PaCO2 is greater than 50. And you can see the normals here. We've discussed those before. So respiratory failure is when these are out of whack, and they can be out of whack either way. The reason for respiratory failure can be a million different things. Most common is probably a pneumonia or some sort of an infection. Trauma, a cardiovascular event, an allergic reaction, which causes anaphylaxis, pulmonary aspiration, so we've sucked something gross into your lungs. Lots of different things can happen. If there's a mechanical problem like a pneumothorax, a pleural effusion, severe abdominal distension can cause respiratory failure. If you have an ET tube, an endotracheal tube, and you don't have the ability to clear your secretions, Guillain-Barré, muscular dystrophy, muscular sclerosis, all of those things can be precipitating factors to respiratory failure. Signs and symptoms: apprehension or anxiety, restlessness, fatigue, headaches, dyspnea. Again, you're just short of breath, but you're still doing okay. You just don't feel well. At this point, the patient's lips might be turning a little bit blue. Their pulse ox might be dropping. And then full-blown failure is confusion, tachypnea, cyanosis. The heart goes crazy with either tachycardia or SVT or God only knows what, depending on how bad it is. Again, depending on the cause of it, you can have congestive heart failure, and then ultimately respiratory acidosis, and then respiratory arrest, which means the patient stops breathing. So obviously this is emergent. Our first line of defense is oxygen, and then this patient will be intubated so that we're pushing the air in and we're sucking it back out. We are going to do whatever we can to reduce the secretions. They'll be given a lot of drugs that help clear secretions, that help with breathing, and again, we're going to correct the acidosis. So think about how you would correct acidosis. And again, this goes into all kinds of different things, but remember, if you're acidotic, you need something that's alkalotic, so you would treat acidosis with bicarb. You would treat alkalosis with CO2, something acidic. Don't get into all that worry about ABGs. That's a little FYI thing. But when you think about correcting acidosis, the way to correct acidosis is with bicarb. Occasionally, a patient is going to have thoracic surgery. A thoracotomy, which means they remove the lung. Chest tube insertion usually happens following cardiovascular surgery. There are a lot of different kinds of surgery, but a thoracotomy is they put an opening in the thoracic cavity, and then usually a section of the lung is taken out, maybe a lobe, maybe a section of the lobe, usually a tumor is the reason for this. And post-op, just like with any surgery, but you're going to check the dressings, coughing and deep breathing, incentive spirometry, put something over the incision, like you'll teach the patient to hold the incision when they're slowly breathing so that it's not as painful. And they might need O2 and they might need some suctioning because coughing is really hard following that kind of a procedure. A chest tube is it's placed in the pleural space. We talked about this before. It's usually for a pleural effusion, pneumothorax, hemothorax, and it's either to remove air or to remove blood or any kind of fluid that can be in the pleural space. Again, you see this a lot after cardiovascular surgery. You'll see chest tubes. Unless you're working in a hospital situation, you probably won't see a chest tube because people don't have them chronically. This is an acute thing. Let's talk about the normal pressure of the thoracic cavity. Remember that the pleural the pleura covers the lungs. That's like the balloon that holds the lung. And in that pleural space, there's a lubricant. And that lubricant keeps the lungs moving and elastic. And if that elasticity is bound for whatever reason, like we talked about before, then the lungs can't move. And if the lungs can't move, they can't take air in and out. Appropriate pressure creates a negative pressure, which keeps the lungs inflated. So you can, diaphragm pulls the lung down, and that lets you inhale. Then when you exhale, the diaphragm pushes up, and that lets the air out. And if that pleural space does not have the appropriate space in it, like if it's clogged with fluid or if it's clogged with air, then the lungs aren't moving how they're supposed to move, and there's no negative pressure. Again, we talked about that a little bit before, but this gives you a slide that kind of puts it in the actual words. Here on this is a YouTube video. You can open up your PowerPoint and link this to it, and it really does explain what a chest tube does and how it works. And I am not going to go over it because I want you to watch this video. So you can stop this video and pull up that one if you want, and then you can follow along with these. This is what a chest tube looks like, and this tube right here comes from the patient, and you'll see these cylinders. It starts right here, building up with fluid, and then it falls over to this one. And that fluid can be clear, it can be blood, it just depends on what's going on with the patient. And then here is another tube, and this goes to the suction canister on the wall. And right here is the suction control, and this is under water pressure so that no air can get into it. And again, that's very brief. When you watch the video, this will all make sense to you, but here's how it comes through. I like this picture a lot because you want to see this, and you don't want a lot of bubbling in here, because if there's a lot of bubbling, there's a lot of air, and you don't want that. But again, that's explained in the chest tube video. Pleural evacuation chambers, this is where it's part of the chest tube that actually collects the fluid. Sometimes that fluid, we mark it with each shift. I'm going to go back to this slide. It's slide 71, and you can see. So let's say they had 40 of output. I would mark this with a Sharpie right here and my initials. And then, okay, so they have a little bit of drainage, a little bit of drainage. They only have 40 cc's. That's not very much. Well, then let's say in the next 8 hours they go to 1900. Something happened. Something broke loose. Something's bleeding. So that's what you want to watch. Now, even though you usually only mark the cylinder every shift, when you hourly round, you always check it. You want to make sure that it's in place, that the suction's working right. It's an amazing tool. It keeps people alive very well. And then you actually record the drainage that's in here as output. This does not get emptied. It gets completely disposed of when it's full. So when you get to about here, you clamp this off from the patient, clamp it off to suction, and you replace it really quick, because if you don't, their lung will fill up with fluid or air. So it's a very, very specific way of changing that, and again, that's all in the video. Let me see. This talks about the water seal, and you're going to see that in the video. I'm moving on here because all this is in the video, and then it just refers to it. So, nursing care. Prevent air from entering the pleural cavity. So this thing has to be water sealed. You want to check all the connectors. Never, ever, ever lift the chest tube above the chest of the patient. It's very, very important that the tubing is never over the side rails, because then it's above the chest of the patient. So if this is the patient, it's hard for me to draw here, and you know how much I like to draw, but let's say this is your patient laying down, this title right here. And this is their head. You want their chest tube way down here. It's usually by the feet, so that it goes down. So you don't want the tubes coming up over the bedside table and then down. You always want them to be lower than the patient's chest. That's very, very, very important. You want to make sure there's no kinks. I remember one time we had a patient who had an issue, and it turned out that actually the respiratory therapist had moved the bedside table and hit the tube, and it kinked it, and patient ended up being fine. It was just one of those crazy weird things. You don't flush this, you don't milk it, you don't do anything like that unless there is a specific need in a specific order, and I can't even tell you why there would be, because that would be a very dangerous thing to do. Nursing care has more to do with watching to make sure it's in the right place and watching the dressing. Remember, where they insert it, it's like they impale right in between the intercostal spaces of the patient's lung. So it's a hole, and you have to make sure that no air can get into that hole. So there's a gauze dressing that is like a Vaseline dressing that's on it that covers it. You can see right here, this patient has, I've only seen a patient with 2 chest tubes. This looks like this patient has 4. I can't tell if they're chest tubes or drains, though. These might just be drains. But you can see where they put them in. And usually it's kind of a thinner tube coming out of the patient, and then it gets, as it comes down here, it's a thicker tube. Next thing we're going to talk about, and actually very quickly, and we're almost done with this unit, but we're going to talk about tension pneumothorax. And this is where air enters the pleural space, but it can't get out. So this happens if the chest tube is clamped for more than just a couple of seconds. Also, if there's an air leak in the chest tube system. A lot of times our treatments can be more dangerous than the treatment, so you have to really, really be careful. Whenever you have a chest tube on a patient, you almost always have a standing order for a chest x-ray. So if anything goes awry, you can order a bedside chest x-ray and have that ready for when you call the doctor. And you can get those usually pretty quick. Again, that's going to depend on your facility, and you won't see chest tubes unless you're actually in a hospital setting. If the tube is accidentally disconnected, there's all kinds of rules about what you do with it and what happened to it. But of course, you want to clean it. You want to keep it as sterile as you can. If the tube gets pulled out, God help you if that happens. But you have to put a Vaseline gauze dressing. I always kept one at the bedside, or 2 or 3. And then you have to apply pressure, and of course this is emergent, and you have someone call whatever doctor's in the house to come up and help you. The patient won't bleed to death or anything like that, but you got to make sure that no air gets in there. And chest tubes are removed by the doctor. Now, when I worked as a cardiovascular nurse, I was certified to remove them, but I usually only remove them in the presence of a doctor. If the doctor was there doing something else, there had to be a doctor or a physician's assistant within, I don't know how many minutes, but I hardly ever took them out. But I could if there was emergent necessity to do that. A pneumectomy, that's when they remove the whole lung. And this usually happens in a cancer patient situation. People can live with one lung, and they can live well. It's just healing from the surgery. It takes a while. There's usually not chest tubes because they usually don't have a lot of fluid or exudate on that side. Again, it's usually done in the event of cancer or severe injury. And then finally, here is a good slide for how to take care of the thoracic patient after they've had any thoracic surgery. So you want to review this, and then in class we're going to go over most of these disease processes, and we're going to care plan them, make some concept maps, and really bring this unit into a visual learning experience for you. So thanks for tolerating the videos. I hope they're helpful, and I look forward to seeing you in class.